Welcome to our final lesson in the abdominal module for our point of care ultrasound curriculum. Today, this is going to cover the renal and urinary tract ultrasound uses. Let's start by going over some of the indications for a renal ultrasound. So our friend Thanos would say everything. Basically, anyone that comes in with undifferentiated abdominal pain, hematuria, or flank pain, if this is a patient that has urinary catheter concerns, recurrent UTIs, there's just a ton of reasons why you might want to do a renal ultrasound, especially given the high safety profile of this exam. And so this is one of those things that I find that we order so frequently in the inpatient setting for our hospitalized patients, and that we often think about ordering in the outpatient setting as well, when a lot of the clinical questions that we're asking when we order those scans are things that we could look at ourselves using point of care ultrasound. So we're going to go over a little bit about that. The evidence for renal POCUS is supportive of most indications for the exam for a point of care study as compared to a formal study. As an example of this, here's one study that was published in the New England Journal of Medicine that looked at getting a POCUS scan versus a radiology scan versus a CT scan for a complaint of suspected nephrolithiasis. And what they found was that there was really no difference at the 30-day incidence of a high-risk diagnosis, meaning that point of care ultrasound and radiology ultrasound were not inferior to a CT study at finding these types of concerns or these types of pathologies with nephrolithiasis, but that there was a 6-month cumulative radiation dose exposure reduction in the groups that got an ultrasound first. And so, when I think about how often we are looking at kidney disease in patients and how often we get CT scans on patients, especially in the inpatient setting, reaching for that ultrasound machine first might be a good way for us to reduce the harm of our patients without sacrificing diagnostic capabilities. So just something to consider. It's only one study, but there is more evidence out there for similar findings for POCUS. Let's go over how to perform a renal ultrasound. And you'll discover that once again, many of the similar things that we've seen on previous lessons in this module, we want to continue to use our curvilinear probe, which has the best depth to resolution profile for abdominal structures. However, because of the kidney's locations behind the thoracic cage, we may want to utilize the phased array probe if one is available, if we're having trouble navigating between those kidneys or between those ribs to visualize the kidneys. Generally, we're going to want our patients to be supine for this exam. Every now and then we may want them to roll laterally to the lateral decubitus positions, but generally a supine patient is going to be best visualized for our renal ultrasound. Oftentimes, because the kidneys are posteriorly located and sort of obliquely oriented, with the inferior pole of the kidney being more inferior and more anterior in the body, you'll have to have your knuckles to the bed, especially on the left side, and really kind of go posterior as far as you can to visualize these kidneys well in the longitudinal and transverse planes. Let's go over our normal kidney anatomy and what it looks like on ultrasound. So the anatomy can be roughly divided into the renal cortex, the medullary pyramids, a renal pelvis, and a ureter. And each of those has a unique appearance on ultrasound that we went over on our normal anatomy lesson, the very first lesson in this module, but let's go over it in a little bit more detail here. So here I have colorized these images to help us better differentiate the anatomy. So we have our renal cortex, our renal parenchyma in yellow, surrounding the medullary pyramids, which here are in teal and often appear anechoic on ultrasound. We have a renal pelvis that, while it does collect fluid, often appears hyperechoic at the hilum because of the fibrous connective tissues and nerves and vasculature and fat that collect right there at the sort of crease of the kidney bean. And then if you are able to see a ureter, it'll appear as an anechoic line that I've highlighted here in green. So knowing your anatomy is important to be able to differentiate what is normal and abnormal as we dive into the more detailed discovery of the anatomy for these organs. So let's go over the exam technique. So to start this probe, or start this exam, you're going to place the probe in the mid-axillary line, longitudinally with the indicator pointed towards the patient's head. And then what you'll do is you'll translate superiorly or inferiorly, and most common it's going to be superior because we often start way too low, until that kidney just pops into view. Oftentimes we'll have to use the liver or the spleen as an acoustic window if we're not able to directly see the kidney. And then once you've centered that organ on the screen, what you'll do, as demonstrated in this clip, is rotate your probe slightly posteriorly. And you'll notice that that's in the direction or the orientation of the ribs to kind of fit into an intercostal space. And not only will that avoid the rib shadows that you could otherwise get, it also helps us align our probes with the longitudinal direction and oblique orientation of the kidney as it lies within the body. And then once we've seen that view, we'll fan back and forth to get a good longitudinal view, and then rotate 90 degrees for a short axis view. Some tips and tricks: remember to palpate before you place the probe on your patient. So if you palpate and kind of find a rib space that you think is going to be kind of targeting where you expect the kidney to be, and then place your ultrasound probe there, you're going to have a much higher success rate at identifying it quickly. You'll need to go posteriorly. Most often when I see people having trouble identifying the kidneys, it's because they're too anterior on the chest or too lateral on the abdominal wall. These kidneys are retroperitoneal structures. They lie close to the vertebrae. You need to go posteriorly, especially on the left side. That left kidney can be tucked away just next to the spine, really high up behind the ribs, and you really kind of have to be hugging your patient, knuckles to the bed, to visualize it. In symptomatic patients, so let's say someone comes in, you're worried about a kidney stone, they've got right flank pain, start looking at the left side first. So in general, the asymptomatic side first, because you want to get a sense of what a normal kidney looks like for them before you compare to the side that may have pathology, because there is a little bit of variability in the way that the kidneys can appear from person to person. Remember that you can utilize acoustic windows with the liver or the spleen to better visualize these structures. And the patient should be instructed to void prior to an exam to avoid false positives for hydronephrosis. So just physiologic retention of bladder in the, or urine in the bladder can cause some dilation of the ureter. And so have your patients void to prevent calling a false positive if they're able to do so on command. Let's start by looking at the right kidney. So the kidneys, while they look very similar, do have some slight differences. The first being their location. The right kidney is generally more anterior and inferior than the left kidney, and it's also usually slightly larger than the left kidney, although they should be roughly similar in size. The right kidney is generally located between the 10th and 11th rib intercostal spaces, and that will help you if you palpate, sort of that lower margin of the rib, find the lowest rib, and then go up a couple of rib spaces. You should be able to see the kidney in that space. And I like that because you can think of it as the 10th and 11th rib space, and it's also supposed to be about 10 to 11 centimeters in length. And although that's variable, it does give you a rough estimate about when you're making a measurement of the size of the kidneys, to kind of remember, okay, it should be about the same rib space as it is length. Just a small little mnemonic there. Let's go over the left kidney now. So compared to the right kidney, the left kidney is more superior and more posterior, like I mentioned previously. It's also usually slightly smaller, although both kidneys should be within about 2 centimeters of each other in size. And so if you're getting one kidney that's measuring, 3-4 centimeters larger than the other, regardless of which side it's on, you kind of need to start looking at renovascular disease or atrophic kidney disease, or congenital kidney malformations, or even maybe something like severe hydronephrosis and swelling. You should start this scan rather than in the mid-axillary line, closer to the posterior axillary line. And you may need the patient to roll or take a deep breath to inspire and move that diaphragm and kidney down low enough so that you can visualize it. So that's pretty much it for normal appearance for the kidneys. Let's go over what a normal urinary bladder ultrasound looks like. Once again, we're going to utilize the curvilinear probe. You really kind of want to prefer the curvilinear here over the phased array because of its wide footprint. This allows for the best view of the whole bladder. And then once again, we will have our patient in the supine position for this exam. Starting off, we want to visualize the bladder in the longitudinal and the transverse axes. So here we have on the left a longitudinal view of the bladder, which represents an anechoic structure in the near field close to that probe. Right over, we see the pubic symphysis up at the right upper corner of the screen with some posterior acoustic shadowing. And then we see the bladder peeking out from behind it. And that bladder is filled with anechoic fluid that as we sweep through and fan through the bladder, we see no like irregularities or collections of fluid outside of it. Then we can rotate our probe 90 degrees and see it in the transverse axis, doing the same thing, fanning through the entirety of the bladder to get an estimate of its volume. If you wanted to calculate the volume of the urine in the bladder, you can do so by taking measurements of the length and the width and the height. So you'll need to do it in both planes and get 3 measurements. And then you multiply those by a correction factor. Generally, we would use like 0.7, 0.71 as that correction factor, although really what you should do is look at the shape of the bladder and then look up the correction factor for that shape. So a cylindrical bladder will be different than a spherical bladder, will be different than a trapezoidal or cuboidal bladder. But you know what? That's kind of complicated, and the machine does a pretty dang good job of doing it for us. So most modern machines now have an automated sort of bladder scan metric or a volume metric that you can set, or when in doubt, you can just use a bladder scanner, a dedicated bladder scanner, which does this with some artificial technology that works pretty well. But if you ever get in a situation where you want to calculate it yourself or just try to estimate it quickly, that's how you would make the measurement. Another thing that's important to look at in the bladder is the presence of urinary jets. So urinary jets refer to where the ureters empty at the bladder trigon, and you can see, periodically about once every or twice a minute up to once every 2 minutes, those ureters sort of having a little contractile process that forces urine into the bladder and makes this cool kind of volcano looking, some people call it the crossed lightsaber appearance. That you can see on color flow of that urine entering the bladder. Now, a couple things that are important to remember is that you don't have to see these happening at the same time. You can get one side and then the other, and they may not be synced up, and that's totally normal. The other thing is that seeing these is dependent on having your color flow set at the right scale and over the right area of the bladder. And so you want to make sure it's a pretty low scale, up to about 20 centimeters per minute of flow, which most machines are going to have that kind of normally set. So you don't need to tinker with the settings too much. But if you're not noticing them before you say, oh no, we've got obstruction or we've got some disease, just take a look at your scale and make sure it's not too high or too low. And then the other thing is that it can take some time for you to see these. So sometimes you have to sit there for 3-4 minutes before you see a jet. Especially in a patient that is dehydrated or in patients that do have some obstruction. It may take longer for these jets to appear and they may be weaker. So that's just something to keep in mind. This is kind of a fun little thing to look at, and it's always brings a smile to my face when I see a urinary jet, which is probably, there's some Freudian psychology in there somewhere, but that's beyond the scope of this lecture. All right, so now that we've seen what normal anatomy looks like, let's go over renal and GU pathology on ultrasound. And let's start with our good old friend hydronephrosis. So hydronephrosis refers to enlargement or distension of the kidneys, which is usually caused by obstruction or urinary retention or bladder dysfunction. So your differential diagnosis includes, amongst other things, stones, prostatic hypertrophy, masses, tumors, bladder dysfunction, Foley dysfunction, things like that. You grade hydronephrosis subjectively, which can be a challenge, especially if you haven't done a ton of kidney ultrasounds. This diagram I took from POCUS101.com, a great resource, by the way, which I would highly recommend utilizing. But it kind of explains that, as you progress from mild hydronephrosis to severe hydronephrosis, you start to get more and more invasion of this swelling into the renal parenchyma. And so mild hydronephrosis, you'll get just a little bit of pelviectasis or swelling of that hilum or that renal pelvis that usually is sort of obscured by the fibrous connective tissue and appears hyperechoic on a normal kidney. You start to see some anechoic components within that renal pelvis. As the hydronephrosis progresses, you start to invade the major calyces and then eventually the minor calyces. And so once you're starting to see the calyces being invaded and swollen, filled with anechoic fluid, with continuity between those calyces and the renal pelvis, that's when you would start to say, hey, there's some moderate hydronephrosis present. And then by the time that you start to get cortical thinning or invasion into those cortical zones, the renal parenchyma itself, and you see thinning of that structure, that would be severe grade 4 hydronephrosis. So, subjective scales are always challenging, but I would urge you to just look at as many patients as you can, especially patients that have been already diagnosed with hydronephrosis before you've started therapy, before you've placed a Foley, or before you've diuresed, or whatever it is that you're trying to do to improve that situation. Go throw an ultrasound on real quick and take a peek at what that looks like on that particular patient. And with time, you'll be able to differentiate this yourself. Let's go through some examples of hydronephrosis. We'll start with this one here on the left. So in this view, we have a kidney. We see some medullary pyramids. We see a nice, healthy, intact renal cortex. But down at the pelvis, instead of seeing a uniform sort of hyperechoic area, you start to see a little bit of anechoic fluid collection in this renal pelvis, like right here, starting to kind of fill this zone. And so this would be an example of mild hydronephrosis. As we progress to moderate hydronephrosis, we start to see that the anechoic fluid in this kidney, in this case the right kidney, is starting to invade those calyces, and we start to see swelling of the major calyces, maybe even some of those minor calyces up here. And so this is a good example of moderate hydronephrosis. And then lastly, in this kidney, you can hardly tell that this is a kidney at all because almost all of this renal parenchyma has been pushed off to the side and compressed by the overwhelming swelling of these calyces and invading the renal cortex. And so this is severe hydronephrosis. Let's move on to nephrolithiasis or kidney stones. So kidney stones are common problems. They result in over 3.5 million ER visits or clinic visits every year. And typically patients will come in with severe unilateral pain, nausea or vomiting, sometimes hematuria or fevers and chills. And this can be a pretty significant condition. So oftentimes it is not subtle in presentation, although every now and then, you'll get someone that you think has one thing and turns out they had a kidney stone instead. But we so often will reach for a CT scan to diagnose a kidney stone, but really, especially in pregnant patients and younger patients, an ultrasound is often a good option for initial evaluation. There are a few ways to diagnose a kidney stone or to visualize a kidney stone on ultrasound. And the first is direct visualization. So if there's a stone that's inside the kidney, it's often going to appear as a highly echogenic surface with posterior shadowing. And that's exactly what we see here. So we got our kidney, our pelvis, here's a medullary pyramid, the cortex here on the outside, here's a piece of the liver, and then we've got this irregular hyperechoic structure, and we've got posterior acoustic shadowing underneath. So this is a kidney stone seen inside the kidney. If you don't happen to see direct visualization, sometimes you'll just see the downstream effects, or rather upstream effects in this case. So if the stone has passed and is now in the ureter, or down at the uretropelvic junction, you may see just unilateral hydronephrosis. And this is why it's important for you to look at the unaffected side first. So if a patient's having unilateral flank pain, go ahead and take a look at the opposite side, see what that pelvis looks like for that particular patient, then flip over to the symptomatic side and see if you see some of this hydronephrosis. So in this case, I would say we've got mild, maybe mild to moderate hydronephrosis here. And in this case, there's a distal kidney stone lodged in the ureter that was resulting in early obstruction. So one clinical question that is sometimes asked is, does the degree of hydronephrosis on ultrasound predict the size of the kidney stone? And the reason this matters is that we know that kidney stones that are larger than about 5 millimeters are less likely to spontaneously pass than those that are smaller. And so it would be helpful for us to be able to look at the degree of hydronephrosis and predict which patients are going to be able to be managed expectantly and with pain control, as opposed to patients that are going to need stenting or going to need surgical removal. And while there is an association with size and hydronephrosis, it's not super duper strong. So patients with none or with mild hydronephrosis were less likely to have a kidney stone greater than 5 millimeters with a positive or negative predictive value, of 0.876. So while decent, it's not the best, and it's sort of an indirect measurement that if you're going to, decide whether or not you're going to admit this patient or send them to urology, I would be cautious about interpreting one study so far in this way. However, a well-designed study that is helpful for letting us know, if we're seeing massive hydronephrosis, for sure we got to send those patients to get evaluated. If we really don't see any and we're really confident in our skills, we may be able to manage these patients in our offices or at home with good ER and clinic return precautions. Moving back to our findings for kidney stones, this is twinkling artifact, which I brought up with gallstones earlier on. But this is an example of the first place where twinkling artifact was really highly valued as being subjective of a stone. And you can see here that in this view, a transverse view of the bladder, on the patient's left side, on our right side of the screen, at the ureterovesicular junction, we've got this kind of bright area down here, and there's this one punctate spot of brightly twinkling reversible color on Doppler color flow. And this is the twinkling artifact that is very suggestive of a stone at that junction. And here you can also sort of see some posterior acoustic shadowing, but sometimes because of the posterior acoustic enhancement, where structures deep to the bladder will often appear brighter, those stones can be sort of missed, or that shadowing can sort of be diminished. And so if you're suspicious that there could be a stone there, go ahead and put on some color flow, and if you see this twinkling artifact, you can be more suspicious that there's a stone present. Here's an example of the many, many, many studies out there that look at the twinkling artifact. And honestly, the evidence is a little bit conflicting at times. The takeaway is that it seems to be pretty predictive of stones, especially when seen at the uterovesicular junction. Sensitivity is likely to be 90% or higher for stones that are larger than 5 millimeters, and probably approaches 100% specificity. But like any test, when we see this patients who have known history of stones or with other findings that we've talked about, it's probably going to be more highly predictive. I also want to shout out this study, the best title ever from this group of Romanian physicians, Twinkle, Twinkle, Little Stone, an artifact improves the ultrasound performance. I love that study name. I hope that someday I can produce a study that has such a good name. And moving on to our last finding suggestive of stones is the unilateral absence of a ureteral jet. And so here we've got this patient who let's say that this was a scan over the course of 5 minutes. It's not, it's just a few second clip. But if we had sat here for several minutes looking at this patient's bladder and we see consistently this jet originating from the left ureter, but nothing originating from the right, that would be suggestive that perhaps there is a stone or some sort of obstruction of that right ureter. Here we have the money shot view of a left-sided jet and a right-sided twinkle artifact with just a small partial jet, which is basically diagnostic of a stone at the right ureterovesicular junction. So this is a cool shot. If you get this one, man, A+. Let's move on to talk about some other pathology, including renal cysts. So renal cysts are anechoic collections of fluid adjacent to the kidneys that are thin-walled. They should lack internal septations, and they do not communicate with the urinary collection structures. They are located in the renal cortex or in the renal pelvis, but because they do not communicate, they will be kind of isolated and thin-walled and will not drain spontaneously. Renal cysts are super common. These criteria apply to simple cysts, which are ones that can generally be managed expectantly or by following up at regular intervals with repeat ultrasounds. However, there are things that can make you more suspicious of other pathologies. So if there's septations or debris inside here, if they're extremely large, or if they have an atypical appearance, those would be ones that you might want to send off for study because it could be a renal abscess or some sort of other malformation. But simple cysts are pretty common and often seen in patients incidentally. Here are a couple clips of some renal cysts. So here on the left, we see the liver, we see the gallbladder up here, and then we see the kidney here down in this right section. So here's our renal cortex here, and then this is the renal cyst. And so I included this slide because sometimes the gallbladder can be located really close to the kidney and can be mistaken for a renal cyst, but you see it really doesn't have any relation to the renal cortex itself. And so that's how you can differentiate a gallbladder from a renal cyst. This renal cyst is going to move with the kidney, with inspiration and respiration. It's going to be immediately adjacent to that renal cortex or pelvis and be anechoic. So that's a large right renal cyst. And then on the right side of the screen, we have an example of polycystic kidney disease in a patient that has genetic risk factors for polycystic kidney disease. And so we see the renal cortex, but it's broken up by just numerous collections of simple anechoic fluid. This one maybe have a little septation in it, or it may just be kind of the way we're catching it. I'm not really sure. We need more images there. But this is what a polycystic kidney would look like. So, remember that POCUS is a tool to answer a focused clinical question and not a full imaging study. And so while we've gone over a few of the indications for a renal ultrasound and a few of the findings, there's a lot more that can be done in a formal renal ultrasound. So formal renal ultrasounds can take a look at the flow of the vessels that are going to and from the kidneys. They can use higher types of Doppler and higher types of resolution to better image things. So when in doubt, don't deny your patient that full imaging study if it's something that they need. But to start answering a clinical question, to try to cut down on time to get seen or managed, utilize your point of care ultrasound because it's a helpful tool that has good evidence with even a growing body of literature that suggests it's helpful for looking at the kidneys and the bladder. So as a review, in this lesson, we talked about ultrasound indications for renal pathologies. We reviewed a little bit of the evidence behind how we can utilize POCUS and back it up with some science that says it's helpful for clinicians like you and me. We talked about the exam technique and looked at the normal anatomy of the kidney and the bladder. We looked at hydronephrosis, we looked at kidney stones, and a variety of other renal and GU pathologies. And this sums up the end of our ultrasound module for abdominal POCUS. There's a lot of other ways that you can utilize it. We didn't even start to talk about splenic ultrasound or pancreatic ultrasound in detail, but there's a lot of really cool stuff out there that if you do an elective with me, or if you want to do some independent study, that you can learn. But this is a good introduction for this module at some of the different uses of point of care ultrasound that we can carry to our clinic or carry to our inpatient services. And I hope that you'll stick around for our next module, which should be coming out pretty soon. Thanks.